The ETP webinar will start in just a few moments. This is Harley from BlueSky Behavioral Health in Danbury, Connecticut, and I want to say thank you for watching our monthly webinar series. The following presentation is about exposure response prevention therapy, one of the unique treatments offered at BlueSky. Presenting will be Rob DeLetis, our drug counselor.
Thanks, Harley. Good morning, everybody. Today we're going to be talking about ERP, exposure response prevention. I've been doing the ERP sessions for about 22 years now, and I've been probably have 12,000 sessions under my belt. So today we're going to learn how to do ERPs, rationale, reason, talk about a whole bunch of different aspects of this process that is going to help your clients in the recovery. ERP is not a cure-all. I'm going to say that a lot today, but in combination with exercise, 12 steps, medication, nutrition, exercise, different approaches. This is a different approach to get people going to help them learn about things, and you will see that in a few minutes. So let's get going. Today you're going to learn how ERP can be effective for your clients, the rationale and reason for ERP, how to learn about aspects of the ERP sessions, and I'll give you a rundown of how to do a session and what to expect and a whole bunch of different other things regarding these sessions. And during this time, if there's any questions, feel free, like Carly said, you can type them in. You could, if you want to say them to me, that's fine. But for now, here's a quote I found on addiction. It's actually very good. People understand it. It kind of talks about everybody. If you want to substitute the word alcohol with your drug of choice or self-destructive behavior choice, that's fine as well, because it kind of fits everybody. Found this years ago. It's still true to this day, and people understand it, and they get to it. The clients truly nod their head and say, yeah, I get it. So let's keep going here. If you're not sure what ERP is, quick explanation. Exposure response prevention, mainly used for obsessive compulsive disorders and phobias. Probably around 40, 50 years ago it started. So what we've done here is taken the principles of the ERP and I use them for recovery and substance abuse. So here I expose clients to their drugs of choice. Let it be, I can do alcohol for alcohol, crack, pills, you name it, I can do it. I do ERP with alcohol, coke, crack, marijuana, heroin, designer drugs, cutting, sex, gambling, eating disorders, a little bit of everything. So if the self-destructive behavior has gotten people in trouble before, they don't expect to come to Danbury, Connecticut and see a beer, hold some pills. In my office, I have a really well-stocked bar. I have acrylic water pipes or bongs in my office. I have booze. I have pills, a little bit of everything. Because again, clients are used to treatment traditional way, and in combination with a whole bunch of different things, this is an instant rapport builder for everybody. So in the past, people are expecting to come to treatment and see the traditional things, groups and therapy and medications and a whole bunch of different things. They have no thought of seeing any of this stuff throughout the sessions or throughout their stay at BlueSky here. So the reality is the ERP works because it exposes people to their drugs of choice. The drugs of choice that I have are simulated. I show somebody a crack vial with simulated crack inside. Their pulse is automatically going to go up. They're sweating. They're going to have a whole bunch of behavioral responses to this because, again, they've never really seen it in a controlled setting and been around to it. Let's continue. Vocabulary words for ERP. Cognitive scripts. We'll get to those a little bit later, but what those are, 9 positive mantras. 9 positive mantras of what you can do when you walk away from your addiction, as well as 9 negatives have occurred because of your addiction. I'll give you an example in a little bit when we talk more about the cognitive scripts, because that's the meat and potatoes of the ERP sessions. Operant learning, conditional learning, stimulus, positive reinforcement. I'll get to those a little bit later as well. If you look at this slide I have, this is from a good book, Addictive Behavior Cue Exposure Theory and Practice. It's a really good book. It kind of sums everything up about ERP. If you read it in a nutshell, it says this therapist was talking to one of his clients, pulled out a bottle of Jim Beam, and the client instinctually just put his hand in front of it like he was going for it because he's so ingrained, once you see it, I must go for it. So that's what this is all about. And if you look at the world we have in, if you go to a restaurant, what's the first question they ask you? What would you like to drink? If you're on an airplane, what's eye level with the seat? The beverage cart. If you go across the ocean, go abroad. How many bottles of wine would you like, Mr. DeLetis? And they'll give you whatever you want. If the triggers and the sights, the stimulus are all around. Sights, sounds, smells, everything. The example I use, if I grew up smoking pot with somebody and we listen to Bob Marley is a trigger. So during the sessions, which you'll hear a little later too, I put the music on. I pull out the paraphernalia. I pull out the papers and the cognitive scripts. And we'll go over a session in a little bit. The hardest part of the ERP is knowing what to expect. Over the years, these are the things that I have encountered regarding the sessions. And again, I never know what somebody's going to do. So the reality is, if I put somebody in a session and not knowing how they're going to react, I have to portray confidence. I will not do this with everybody. If somebody's psychotic, I will not do ERP sessions with them. I will do sessions with somebody who just came out of rehab, detox, and I'm good with that. And if they're willing to do it, and it's a voluntary program, it's not a mandatory part of treatment here at BlueSky, but it's an optional part of the program. It is intense. And all these things you see in front of you, expectations, double them, triple them, because once you actually are in the room with somebody, it's truly one of the most intense things a client will talk about. And I'll go over that in a little bit as well. There's a guy, the examples I use that are in my head, there's a guy named, we'll call him Lenny, back in the day, did ERP for cocaine. He was sitting there in this session, and all of a sudden, he started sniffling. And I put it in my head for a second, and I go, I don't think Lenny had a cold when he came in. So we started doing the session some more, and he started even more. So at the end of the session, I asked Lenny, do you have a cold? He goes, no, why? And I explained to him that during the session, he was going, and with cocaine, I asked him, do you have the drip in the back of your throat? Yeah, how did you know? Because the brain is so powerful that he equated the razor, the lines of cocaine, the mirror, the music with him being somewhere back in the day, using cocaine and doing things. So all of these things you see on the screen is all about what I've seen during sessions. There are things in here, the nervousness, the anxiety, the sweats, all intense. The first 4 or 5 sessions, people are overwhelmed because they don't know what to expect, the fear, the anxiety. What am I going to do? What am I going to do? I portray the safety. I portray confidence. I portray they're going to be okay. After 5 or 6 sessions, these experiences you see on here start fading down. So they're not going to be as nervous. Why? They're familiar with it. The continuous exposure to the stimuli or to the beer, they get used to the touching it, cold, the smell, because it's up to their nose like that. I make them pour it in a glass, holding it. You can do all these things. And after 5 or 6 sessions, they start becoming more familiar with the routine, which I'll go over in a little bit with you and stuff like that. So it's intense. Talking to them before we set up the first session is always we talk to them, or I talk to them about cognitive scripts, talking about ERP, the rationale, the reason. Again, instant rapport builder. In 30 seconds, I can get a rapport with somebody because they don't ever expect to see this stuff and come to a clinic and get help by being exposed to the drugs of choice or simulated drugs of choice. So a lot of it is you never know what to expect. And the last thing I always write, maybe, is this, the worst. I always expect the worst. Hasn't happened yet, which is a great thing. And I've been doing this for, again, 12,500 sessions about. The worst case scenario is somebody takes my beer, chugs it, takes my pills, go, and hasn't happened yet. So it's pretty good. Again, a lot of it is me portraying the confidence, their safety, and making sure that they are okay. Health and safety is number one in these sessions. The story I tell, there was a woman who, as I'm cooking up the heroin, putting it in the syringe, she holds it. It was capped. She took the cap off and said, what if I do it right now? And by the luck of Jesus and God and everybody, her mother was in the driveway. And I said, well, you're not going home this weekend. She could have done it, but she did not. She put the syringe down and continued it. And she did really, really well. But again, the worst case scenario, somebody takes my simulated drugs or does something and runs down the road or out the office. But again, most people, when you talk to them and you portray the confidence and show them that this is a place of safety, make sure they're going to be good and in recovery, it works. So here's a basic rundown of a session. We always start off with session number 1 is you meet with me, get a rundown of the ERP reasons, rationales. I get a history of their drug use and or consequences they faced. And then we start talking about the cognitive scripts, which we're going to cut up front. Cognitive scripts, like I said earlier, are 9 individualized statements of what you can accomplish when you walk away, as well as 9 negatives have occurred because of that. If you talk to somebody in recovery and ask them, what are the things that the negative consequences have come to you, they'll come up with 10,000. And they're easy to come up with because they're all in the negative aspect in their head about the negative consequences, let it be law, family, let it be whatever. This is what it's all about. The hardest part of the cognitive scripts is to have them come up with a positive cognitive scripts. I'm going to give you some examples in a minute so you understand, because most of the clients who are in recovery just are in the negative mindset, and all they think about is the negativity, the failures, and everything else. So let me give you this real quick. Here's some examples so you know what I'm talking about. There you go. So each one of these cognitive scripts are individualized for the client. They're not for me. They're for them. They have to make sure that they are set for them. I make them come up with their own cognitive scripts to make them think here, here, and all over. Because if I can get somebody to have the cognitive script impact their lives and associate the drugs with the good and the bad, it's more productive. So the objective of the cognitive scripts is to have them come up with the 18 cognitive scripts, meaningful for them. I don't care if they're one word. They don't have to be grammatically correct. They have to be whatever works for them. There's one guy who used to put Newark. I kind of had a feeling what that meant, but he did. And that's all that matters. So when they talk about the cognitive scripts, I don't have to know what they mean. The client does. And these are intense because, like I said, they can rattle off 3,000 negative ones, but have them sit down and do some positive things of what they can accomplish when they walk away from their addiction. That's the difficult part. So these are set up with myself and the client at the first session. And again, I also use these as a tool to see how motivated they are to do ERP. So if I give them the opportunity to do these cognitive scripts and it takes them 4 days to come back, well, there's a problem because how motivated are you for this? Let me just show you something real quick. This is the form I use. It's called the ERP face sheet. On here is a list for me of what I need to know drug-wise, and it's very specific. What paraphernalia you need, what music I need, everything they use. Specific brand of alcohol, what kind of drugs they used, how they did it, everything. On the second page of this is always information about where they used to use, what did their drug of choice smell like. A whole bunch of different things that people don't really expect because those triggers of sight, sound, smells, touch are the important ones. And that's what this form is all about. Gives me a full rundown of what they did, how they did it, what I need to do to make the session more realistic and stuff like that as well. So once the cognitive scripts are established, then we actually start the sessions. First session is you come in my office. As you see, number 1, they do some deep breathing and body scan. So the reality is it's getting them calmed down a little bit, relaxed, because they're already anticipating seeing their drug of choice and stuff like that as well. So I do the best of my abilities to get them relaxed a little bit. And when I do the sessions, I never really tell the client when we're doing it because the anticipatory anxiety, if I tell them we're doing an ERP session Thursday at 3 o'clock and it's Monday, for the next 3 or 4 days, they're going to be in their head obsessing and just kind of stressing out over the whole thing. So sometimes I'll go up to somebody and say, how you doing? Come on, let's go have a drug counseling session. Let's go talk for a little bit. And I'll just say, let's go do ERP. I won't give them time to think about it. And with that lag time, they don't have time to build themselves up. So once they come in a session, deep breathing, body scan, I teach them how to do that. I take their pulse as the measure of seeing how they react. And also I do a craving rating, scale of 0 to 10. How bad are they craving at that moment? So once they get all that down in routine, the clients are pretty good about it. Here we go. ERP, here's a session. If you see the picture up in the top left, there's different levels of ERPs. So level 1, clients are sitting there with me. Their drug of choice is in front of them. Their paraphernalia might be a bat. Since we have cocaine, we'll talk about that. There'll be a mirror, a razor, a bag of cocaine. Whatever music they use is on the radio. During the first level, I will read their cognitive scripts, and they're just listening right now. So they're not doing anything except sitting there staring at their drug of choice, the paraphernalia, listening to the music. Once I complete all 18 cognitive scripts, they give me their craving rating, and I take their pulse. Once that's done, I ask them, would you like to continue? 99.9% they say yes. Level 2, ERP. Level 2 is simple. I start cooking up crack, cooking up some heroin, rolling joints, pouring drinks in the shot glass. For this case, pouring lines on the mirror and getting the razor and chopping up lines and doing things. As I'm doing that, I'm also reciting the cognitive scripts to them and making them repeat them back to me. So once all 18 cognitive scripts are done and they're looking at the paraphernalia, watching me cut up lines of cocaine, listening to the music, and in their head, they're also listening to these cognitive scripts. Once I finish all 18 and they recite them, craving rating, pulse one more time. Would you like to continue? Yes, sir. So once we continue, level 3, they, if they feel comfortable, start cutting up their own lines of cocaine. And as they're doing that, they are reciting the cognitive scripts from memory. So if they get 5 out of 18 cognitive scripts, what I will do is give them the other 13 cognitive scripts with a special word. So if the cognitive script was, remember the pain and hurt I caused my family, I'll give them pain and hurt, and they'll recite the cognitive script, hopefully from memory. So once they get all 18 cognitive scripts, again, put the razor down, stop cutting up lines, I take their pulse, I ask their craving rating, and we continue for level 4. Level 4, repeat level 3. So if they would like to hold their joint, hold the syringe, hold the bottle of alcohol right here under the nose and smell it. If they want to hold the pills in their hand and, play with them a little bit, just kind of feel them, that's fine. And what they do as well, they recite the cognitive scripts while they're holding the beer, the syringe, whatever it is. If they get 9 out of 18, I'll give them the one they did not get with the keywords, and we'll get all 18 and go from there. Once we finish that, the ERP session with that part is over. So what they're going to do with this part, I'm going to put the paraphernalia away. Strange concept. They're going to take the pills and put them back in the bottle. You'll have to make sure you know exactly how many are on the table at the time or in somebody's hands. They're going to take the beer and dump it down the drain. Once they do all that, I put all the paraphernalia away. We come back to finish the ERP sessions, and this is the intense part. They sit down and start talking about what they expect or what they noticed about themselves during the session. If you go back to that chart that I gave you a few of the session expectations, you'll see all these things. And most of the time when we first start doing ERP, they're unaware of a lot of these things. Some people will be unaware that they're sweating. They might notice their leg going up and down, but they're not going to notice some of these little things that I will. So while they're telling me what they noticed, I'm also observing through the whole session what I noticed. And the reality is I tell them things, and most of them are unaware of what I notice. Their pulse was definitely going to go up. Their heart rate's going to go up. Everything's going to go up, 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 up. And once they get more sessions under their belt, obviously the pulse goes down. The craving rating goes down. Some of the expectations you saw earlier go down, or they're not as intense. So people are still nervous. And the reason I take the biomeasure is to use that as a true measure of what's going on. The craving rating could be, it could be 0. One woman had 0 craving ratings all through the sessions. So the pulse is more of an indicator of what's going on. If you show somebody in recovery an alcohol or pills, their pulse is going to go up no matter what. And that's why I use that. So if you look at the ERP sessions, that's what we do. So once they're back in my office again, and we put the pills back, dump the beer down, take the syringe of heroin and squirt it out in the garbage, they sit down, do some deep breathing, more body scan, and I sit down and write down the observations that I've noticed. Talk to them again. The hardest question is, what are you going to do when you walk out of this office when you have cravings? They're so used to using and doing things that they don't even think about that. So, and I tell people, don't tell me what I want to hear. Tell me what you're really going to do. Well, I'm going to go to a meeting. I'm going to call somebody. Who are you going to call? I want specifics. So I go make sure they have a plan to make sure they're safe and okay for the night. My last question was, how many times you sat there with your drug of choice and put them back? Never. How many times? Never, never, never. You just did it. And at that point, first time, the first session, when they finally realize, I just did it, or I tell them they just did it, the light bulb goes on. And it's amazing. It's like teaching my son something the first time. I don't expect him to get it right away, but with repetition and repetition, you can prove and show yourself how strong you really are. Again, not a cure-all, but with combination with a lot of other aspects of traditional modalities, very effective piece of ERP. So once they start getting going with their automatic boost of their ego, it's kind of weird because the first session when they do this, I just did it. It's kind of like good and bad. I'm not used to this. It's a very weird feeling because on one hand, they want to praise themselves for not doing the drugs or taking a drink or doing anything. But it's weird because that's what they know is normal. And they just broke the cycle or broke the mold. And it's so confusing. And we do a second session or a third session. Then they finally kick it in. Yeah, I just did it 3 times. I dumped the beer 3 times already. Look how strong I am. And again, not a cure-all, but this has been helpful for a lot of people to do the right thing. So once we get the session going, the objective is to get 15 sessions done in 15 days. Once the client is familiar with the aspects of the ERP and the surprise shock value of it all, I can do probably 2 or 3 sessions in an hour. So doing 15 sessions in 3 weeks is not that hard, is not that uncommon, and it's really easy. And again, once they get used to it, the cognitive scripts are in their head. And they're kind of like having this game and see how much pride they can get, how quick I can get 18 cognitive scripts, how many sessions will it take for me to get those? And you could see when I finally said, you got all 18. Nice. Another boost of confidence. So I know those cognitive scripts, when they talk about it, they're in their head because they formulate them and organize them, positive, negatives, family versus this, whatever way they want. But if they connect and hold this and recite those cognitive scripts and get all 18, someplace in there I know that the automatic response of seeing the pills and taking them and going like this could be broken by thinking about the cognitive scripts. Because in the past, they've never had the ability to stop this. It would be an automatic, I got to drink. I got to do the pills. I got to do the heroin. This breaks that automatic cycle. And just seeing them with the, again, I'll say it, confidence booster is phenomenal. Because this is people who have thought they've never been able to stop their addiction or be strong with their addiction. Well, I proved to them by doing these sessions how strong they really are. And again, I'm going to tell you, it's intense. And the reality is they walk away confused, nervous, scared, happy, whole bunch of emotions. I like to do the sessions early, 10, 11, 12 o'clock. So I know that they have some time to be around groups, be around me, hang out, see their therapist. If somebody's truly questionable and the wall brought down, because the ERP brings the wall down, where truly vulnerable. If I know that they're going to be that way, I'll schedule a therapy session right afterwards. So they sit down with me for half hour, 45 minutes, and they go right into therapy after that. Great concept, and it works. So I plan with the therapist ahead of time. If I know that there's outpatient people coming to the clinic and I don't know what they're going to do, I'll make sure they get a ride to the clinic, to and from, and I'll talk to their families. Because the reality of the 12,500 sessions, somebody hit in my pot probably like 17 years ago, and nobody's been number 2. And again, it's all about the confidence and portrayal that I show them about health and safety, number 1. It truly is about their recovery and not so much about me. So it's intense. There are also people, clinicians, that I would be leery about doing ERP with. If somebody does not know how to prepare the paraphernalia, questionable, because some of the clients are really good. And I'm sure most of them sit there and think about how to get over on Rob because he's not the smartest. And you know what? Watch this. I'll distract him by this and do something else, and I'll get his stuff and I'll run down the road or whatever it is. But the reality is, it hasn't happened. And most of the people who are actually in the clinic here at BlueSky are here for a reason. Most of them are pretty good about wanting to do things. So it's a matter of using their strengths and showing them how strong they are and what they can do and how productive they can be, and not believe all the stuff that they had before that people said they can't do this. They're not as strong. Because if you can sit there for 15 sessions with me, hold the beer right under your nose, at the end of the session, dump it, that's you being strong, 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 strong. And if the clinician is not capable of multitasking 5,000 or 6,000 things at one time and reciting cognitive scripts and cooking up heroin and cooking up crack, they're not doing it. The story I tell is there used to be a clinician a while ago that I trained who wanted to do ERP. I was like, all right, let's do it. So we did it, and he was sitting there. I had him in one of the sessions with a client and one of my other staff who was my co-trainer, and this guy wore like a light blue shirt. And by the time he got out of the session, his shirt was soaking wet because he just thought he was going to like ride it out because the client doesn't know anything. No offense. He was a PhD, so he thought he knew everything, and he came out sweating from head to toe. And it's not so much about whatever you think. There's a systematic way that I set up 42 different steps that everybody does the ERP session the exact same way. So it's not like you can wing this. You have to portray confidence. You have to portray you know what you're doing. You have to portray safety all this one time. And this guy did not do it. And he realized he could not do it at the very end of all this stuff. So that was the thing. The other story I tell is there used to be a gentleman who was an intern with me who was in recovery for cocaine. And he decided that one day he wanted to be trained in ERP sessions. And a lot of it was my concern because I'm thinking, yeah, oh, he's going to relapse. It's going to be my fault. And then I realized it's not about me. Let's give it a shot. So here's a guy. We'll call him Rob. And Rob was trained in ERP. He did ERP and I told him, I'll do the training and I'll watch him. And I did. My staff watched him as well. And there was sessions that he did with alcohol. And that I said, you're not going to do ERP with cocaine. He goes, I don't want to. Good enough. So we had this pact that he would do ERP with alcohol. And I think I set him up for ERP with marijuana. And he did it for like 5 or 6 months. Strong. He was good. Clients were like floored. The guy in recovery is doing ERP. But again, you can't hide from your drug of choice. You can't hide from the triggers. You can't. So this guy was strong enough to do it. And he did really well, and the impact was phenomenal on the clients because they saw this guy in recovery doing things. It was like, nice. Of all the sessions that we've done, again, 12,500, there are times that I stop the sessions. I think I aborted 5 sessions in the whole entire 12,500. Why? Because if somebody's acting up or they're stressed or they can't deal with it, I'll put the stimulus away, hide it. I'll make them do some relaxation, deep breathing, body scan. But then I'll bring the paraphernalia back and we will complete the sessions. So of the 12,500 sessions I've completed, I probably stopped 5 sessions throughout the whole thing. And they get why, and they're okay with it. If somebody truly, those 5 people were the ones who said, I can't do this anymore. And we did more sessions afterwards, but that one time was too intense for them to deal with. Okay, let's do some relaxation. Let's compose, calm down. I'll spend some time with you, and then we'll bring you back to groups and stuff like that. So that's the only time I really get to the point where they're going to like stop a session. And this is what this is all about. One of the things we do in the ERP sessions in BlueSky here, we do different assessments. So the assessments we have are in the book Kill the Craving. And it's activity-based book where they learn about cognitive scripts. They learn about these things. The one I like the most is the financial loss inventory. The clients hate this because we have to actually figure out how much money they have lost on their addiction. And it's not just what they paid, it's what families, insurance companies, and stuff like that come up for their addiction. It's a whole intense group that takes about 2 groups to deal with because some people refuse to do it because they don't want to do it. Some people don't want to look at the reality of how much money families, loved ones, or insurance companies spent on their addiction over the last 5, 10, 20 years, or the last 6 months. It all depends. And then we do this, the balance sheets are how much things you've lost regarding, lost it, come back, sorry. Balance sheets are how different aspects of your life has been impacted by your recovery. Let it be job, let it be intimates, and that's just not it's relationships. It's a whole bunch of different categories that people don't really look at. So I make them look at these things that, because the impact of the recovery or their addiction is not just on them, it's the family, it's the law, it's the legal, it's the kids, it's the pets, it's school, education, energy, whole bunch of different aspects. And the financial balance sheets make you look at those things. And again, intense, intense, intense. So here's the kind of support groups we have in the area. This is what I want to get to. I give people a rundown of what the ingredients for success looks like for them, and they're individualized for each other. So what works for one person is not going to work for everybody. It's not about me dictating to them because I'm the almighty Rob DeLetis, drug counselor. It's them deciding what they need to do for their lives. I'm a big fan of the harm reduction, big fan of motivational interviewing, narrative interventions, meeting them where they are, deciding what they want to do, and give them some tools and some ideas of what they can do to get on with their life. So treatment here is a lot. It's intense here at BlueSky. We deal with everybody. We love people with borderline personality. We love people with depressed, anxiety, cutters, you name it, we have it. But getting them to breathe a little bit, balance, do things for fun. That's what this is all about. The program here is based on those aspects. It's not just 24/7 recovery or stirring up the past and dealing with all those other things. It's about reliving your life and reinventing your life to figure out what you want, have some sober fun, and do something interesting. So all these recipes for success are different for each person. Some people want to go to 12 steps. Some people don't. Some people are on medications. So everybody here does therapy, groups, let it be DBT, drug and alcohol groups. ERP sessions, like I said, are optional, but intense. So this whole program is like a Monday to Friday full-time job. And we also tell them, give some time for yourself at nights or the weekends to breathe, get some balance, and do some things, and figure out how to have fun in life and do things the right way. Any questions thus far?
From Danielle. She's asking if you find that clients will use your sessions as an excuse to relapse?
Good question. No, because most of the time people who are ready to use, it has nothing to do with actually seeing the drug of choice in front of me in their office. It's about the plot and the plan and the methodical piece of it all. The last aspect is actually use. In all the years I've been doing the sessions, not once has somebody left the office or the sessions and gone and used. You know, the thought's always there. But again, when I show them how strong they are for that moment and how well they did and how the first time ever they took the beer and dumped it down the sink, it's not about using. They could have sat there in front of me and done it right here. They did not. So the reality is if I point out all the positives of what they did for those first session, the second session, the third session, et cetera, it builds up the strength, the courage, the whole aspect of how strong they really are. And again, nothing to do with the traditional approaches, but you can't avoid people, places, and things. The reality is you're going to see this again. You're going to see this again. You're going to be around it. You're going to hear this noise. You're going to see this bottle. You're going to do something. And the reality is it's a matter of how strong you're going to be. Good question, Danielle. Any other questions? We're going to continue. So we did a retrospective analysis back in 2000, not a full-scale study yet. Still trying to get that done, and I will get it done. So we did a follow-up. Everybody in the analysis did groups. Some people did ERP. So everybody did groups, one group ERP, one group no ERP. And if you look at it, the outcome is 6 months after they left. This is the one. People who did ERP were still sober at the time, 91% versus 42. And if you look at the people who were using after that time, who did ERP and drug groups, there was 9% who were using versus 58 who just did groups. And those 14 of them were using at the time. Good data. It needs to be, again, a full-scale study. And it's favorable. The outcome was favorable. The idea is favorable. They are attached. There's cognitive script. There's a woman I know who did ERP 16 years ago, and to this day, she can still recite 17 out of 18 cognitive scripts. And she took them and put them in her room, made like 100 copies, put them all over her house, on her ceiling, in her bathroom. So everywhere she looked, she saw the cognitive scripts. And that's what she needed to do for her. There was also people who were on edge, and I believe I went over somebody's house. They were in recovery. I said, before all this stuff goes on and the book came out, I'd like to talk to you and your sponsor about things, about what I'm going to be up against the traditional approaches. So they did, and what I found out is the path that I have regarding recovery is a little different than AA and community support groups, but the outcome is the same. I want them to be sane, sober, and happy. AA wants the same thing. Again, different, more intense approach on my end, and the path is truly different, but the outcome is the same. And the story I tell about that, there was a woman who came over that day who knew of me, but once she saw the copy of the book on the coffee table, she goes, "Oh, you're that guy." And I'm going, "What does that mean?" She goes, "I know what you do." And she was like, won't even pick up the book, won't even look at it, barely talked to me, and was like, ah. And an hour later, I found her in the kitchen looking at the pictures of the book, in the book. I go, "Gotcha." I go, "Why are you doing that?" She went on telling me that she's having a hard time at work. She's stressed out over her child. She was thinking about using because of all these life stressors. And she was so intrigued, and her mind was like, that book, the pictures, that she was in mindset. She didn't use. And again, it wasn't because of pictures in a book or because of that. It's because she was not taking care of herself. She wasn't doing her recipe for success. She said she stopped going to AA as much. She stopped reaching out, and she wasn't taking care of herself. And those are her self-destructive behaviors of a path that was not going to be good. And she's on the path, was on now the path of recovery. One more question.
All right, from Meg.
Hi, Meg.
Can this be used by clinicians in private practice outside of program support for the client? And is there a way for clinicians who don't have personal experience with drug use to do this? And what would the training involve for that?
Good question. We're going to get that in a couple minutes, but the answer to your question is yes. And then I'll speed up a little bit. What I do is I train people, we're going to find out in a few minutes, Meg, about how to do ERP sessions, how to take it back to their private practice or their clinic, whatever it is. If somebody feels comfortable doing it, then that's great. But again, there's some people that I've talked to who don't feel comfortable, or some of the clinics believe that, oh, this is a non-traditional approach. Okay. It's also an adjunct to traditional approaches and everything else. So let me get to that. I'll give you a quick rundown since we have like 10 more minutes left. So what I do is I do trainings for ERP certifications. So if somebody comes here to do the training, they learn how to do the 2-day training. They learn the theories, the practices. They learn how to cook up heroin, do the crack pipe, pour the alcohol, roll a joint, whatever it is. And they practice on myself, and some of the clients here like to help train other clinicians as well. So yeah, certification and training for clinicians only, certified drug counselors and above. Somebody just can't buy a kit. There was a woman who wanted to buy a kit, and I go, "What's certification?" "Well, I have some friends who have eating disorders, and I want to help them." "What's your education?" "I have a BA in psych." No. She wasn't with a clinic. She just thought it'd be really kind of fun and cool, and it's like, well, we're not doing that. So again, the trainings are intense. The sessions are even more intense. Phenomenal rapport building. It works really well. The clients are fascinated by it, and it's like, again, I'm their best friend in like 2 seconds. Do they know I have bongs in my office or really cool things? We're good. You have to have a good personality. You have to be strong. You got to be quick. You got to multitask. You got to do a lot of things, and it's intense. So the trainings are here in Danbury. Oh, let me go back to that. Oh, wrong way. So again, the trainings, the second day is all about you practice, you practice, you practice. You would practice on ERP sessions on myself, where I would be the client and give you the realistic way of what to expect when you're in a session. So again, I do ERP for alcohol, coke, crack, marijuana, cutting, gambling, sex, cigarettes, food, eating disorders, you name it. I can probably figure out some kind of cognitive scripts to do it in some kind of way to make it happen. And the best way to do it is by recreating the scenarios they use. Sight, sound, smells, touch. Taste is really, really, really bad, and that's not happening. once in 12,500 sessions many years ago. So it was good. So we're going to wrap up now. And I want to thank everybody for doing this. So if you guys have any questions, feel free to contact me. You can reach me. You can reach me at the bottom number at 347. If you need to get a hold of me, have any questions. I want to thank everybody for their time and being part of this. Appreciate it. And be on the lookout for the book and CEUs. Thank you, and I'll talk to you soon. Have a good day.